Good morning to all. Today's topic is on gingivectomy. Learning outcomes are choosing of gingivectomy and gingivoplasty procedure in periodontal therapy, carrying out the procedure of gingivectomy. So coming to the introduction, both gingivectomy and flap surgery provide access for root instrumentation. Pocket elimination can be achieved by this resection of suprabony soft tissue pocket in case of gingivectomy, whereas periodontal flap surgery, always pocket reduction will be achieved through soft tissue resection, osseous resection, or periodontal regeneration. Solomon Robichuk is the person who found out the procedure called gingivectomy. He developed a surgical technique that consisted of a scallop continuous gingivectomy excision that exposed the marginal bone for subsequent curettage and remodeling. So the word gingivectomy means excision of the gingiva. So by removing the pocket wall, this technique provides visibility and accessibility for complete calculus removal and thorough root planing. This creates a favorable environment for gingival healing and restoration of a physiological gingival contour. Although gingivectomy was widely performed in the past, improved understanding of healing and the development of sophisticated flap techniques have relegated it to a lesser role in periodontal surgery. However, it remains an effective form of treatment when it is indicated. So, coming to the details of the procedure called gingivectomy, as we told before, it is the excision of the soft tissue wall of the pocket. So, here it aims at the complete eradication of the pocket by removing the diseased pocket wall by this surgery. So, this is a surgical procedure designed to resect the gingival pocket in such a manner that remaining gingiva will heal to provide health, function, and aesthetics. So this aims at the complete removal of pocket. So this can be performed by means of scalpel, electrodes, lasers, or chemicals. So this is the most reliable and predictable method of pocket elimination. Coming to the objectives. So as we told before, the main objective is to eliminate the pocket to achieve normal architecture of gingiva and to provide visibility and accessibility. What are the advantages? That is, it always provides visibility and accessibility for calculus removal and also for smoothing or root planing. Okay, and the technique is very simple and you have good visual access also, and there is a complete pocket elimination will be there, and also you can get a predictable morphological result. So always this aims at pocket reduction surgery. There is comes under the resection surgery, not the regenerative surgery. So always you can expect there is the appropriate attachment or the gingival healthy gingival sulcus after the healing. So what are the disadvantages? Yes, obviously this healing will be by secondary invention, and this is will be a gross wound, so this always can lead to postoperative pain in sometimes, and danger of exposing bone can be in case of thickened marginal bone, so there is a danger of exposing bone, and also by removing or by excision of the pocket wall, this will be leading to decreased attached gingiva. So there is a sacrifice of attached gingiva and also exposes cervical area of tooth, which can lead to sensitivity, aesthetics, or even caries. So then coming to the phonetic and aesthetic problems when it is done in anterior areas. Coming to the indications and contraindications. So what are the indications? That is to eliminate gingival enlargement. That is in case of idiopathic gingival fibromatosis or in case of drug-induced gingival enlargement, or hormonally there is a puberty associated gingival enlargement or pregnancy associated gingival enlargement. So all these are gingivectomy is indicated for all these procedures. And also obviously suprabony pockets in areas with limited access, so this will be done with the gingivectomy for removing the pocket, and also elimination of any suprabony periodontal abscess also can be removed by this, and also minor corrective procedures for correcting the minor gingival discrepancies. So coming to the contraindications, that is especially in case of narrow zone of attached gingiva So when there is a narrow zone of detached gingiva, always this is contraindicated as the it increases the possibility of reduced attached gingiva. And also in case of infrabony pockets, it is not advised as this which does not involve osseous reconstruction. Only the gingival tissue will be removed, so there won't be any osseous recontouring. So that is why it's not indicated in infrabony pockets. And also if there is thickened marginal bone, alveolar bone, obviously this is not recommended as it exposes the alveolar bone. And also in case of aesthetic conservation, especially in anterior maxilla. So, what are the instruments that are used for gingivectomy? So, the probe, mirror, tweezer. So, these are the most diagnostic instruments that you need for all procedures. And for this gingivectomy, we need pocket marker. So, in this picture, it is clearly given the pocket markers. You can have both mesial side and distal side. So, it is called Crane Kaplan's pocket marker. So this is the marker. You can see there one side will be the vertical blend and the other one will be the sharp vertical point. Okay. And we have gingivectomy knives are there. We have kidney shake, Kirkland knife and the interdental type Orban knives. And also we have universal knife. So these are the gingivectomy knives available, and also we should have VP handle with the blades 12 or 15, and also we should have curettes and tissue scissors and tissue nippers. So coming to the details of gingivectomy knives, as you know, this is the Kirkland knife. So kidney shaped knife and have a cutting edge that extends around the entire blade. So this is the entire blade. The entire cutting edge must be sharpened for it. And this is the Orban's knife. You can see that it is two cutting edges of an interproximal knife. They are formed by bevels on the front and back surfaces of the blade. So coming to the surgical procedure, as we told, the first step is the marking the pockets. So this marking of the pockets can be done by pocket marker. Okay, so first we have to probe the area. So probe the area thoroughly, and you can anesthetize before that. Anesthetize the area, probe the area, and this pocket marker can be inserted. That is the blend end can be inserted inside, and the other point will be marking outside. So it will be inserted to the base of the pocket. The level mark, this pressing of the pliers. So this will be providing a bleeding point. So this will be done axially, starting from the distal surface of the last two. Then it will be done anteriorly. So each pocket marked at several places to outline the course on each surface. Okay, so you can see that this is the way how it is done, and this is the pocket marker in position. So this beveled incision will be given after this. So this is the bleeding point. So you can see that this is the area to be done. There is a grade 2 gingival enlargement, and here that is the pocket marker being used for marking the pocket. Coming to the resecting the gingiva, and the next procedure is that we have to give the incision either with a blade or with the knives, with the gingivectomy knives or with scissors or electrocautery. So you can see there with this picture they have used gingivectomy knives. There is a kidney shaped knives for giving the incisions. There is the external bevel incision. There is 45-degree angulation to the gingival surface, and this bevel incision, the internal incision is being done with the Orban's knife. So how to make incision? As we told, this external bevel incision will be given. There is starting at the apical to the points marking the course of the pockets. So this can be either continuous or interrupted incisions. So this should be as close to bone as possible without exposing the bone. So as we told, this incision should be beveled at 45-degree to the gingival surface. So this will recreate the normal fistune pattern, and this can be the same procedure can be done for the parietal side. So for the better contour and to avoid the blood vessels and nerves of incisive canal, always this will be carried along the sides of incisive papilla and not horizontally across it. So there are two types of incision. There is continuous incision and the interrupted incision or discontinuous incision. So continuous incision, as you see in this picture, you can see that this is very continuous. So this is started on facial surface of the last tooth and it will be carried forward without interruption following the course of pocket. So it will be scalloping like this towards the papilla, so leaving a distance, 1 mm distance from the papilla. You can see that this is continuous with this. So you can see that this discontinuous incision there is that will be started on the facial surface of distal angle of last tooth. So this is the distal angle and it will be carried forward following the course of the pocket and extending through internal gingiva to distofacial angle. You can see that this will be stopped here and the next incision it will be starting from the distofacial angle to the next tooth. So next is incision begins in the internal space to distofacial angle of the next tooth. Okay, so always this will be a scalloping type. That is why it is advantageous in preserving the interdental architecture in gingivectomy and in creating surgical papilla and preserving soft tissue over the interdental areas to allow coverage of interdental bone in flap surgery. Coming to the removal of the pocket wall. So after this incision, obviously we will be removing the excised pocket wall and that is with the tissue forceps, and you can clean the area, irrigate the area and examine the root surface. If there is any debris, calculus present, it can be removed. So this is the area that is freed from the tissue. You can see that. So the most apical zone will be consisting of a band-like light zone, whereas the tissues were attached, and coronally to it some calculus fragments can be seen. A root caries or root reception may be found, and granulation tissue may be found. So you can see that in this picture, you can see that first one there is a granulation tissue can be seen in between, and calculus and other deposits if it is present can be seen, and also there is a clear space where junctional epithelium was attached. Then you can after seeing the area, examining the area, you can do scaling and root planing, and we can prepare the tooth surface, and you can cover the area with the surgical dressing. So there is the gingivectomy. This is the case. There is gingivectomy wound after scaling. So this is a whole procedures are given in a, like a flow chart. You can see that this is a planned area for gingivectomy, and then marking the pockets with pocket marker and the bevel incision with Kirkland knife and Orban's knife, and the tissue removal. This is the tissue being removed, and this is the scaling and root planning after the tissue removal, and this is the clinical view immediately, and this is the post-operative view. So this is another case showing this pocket marker with the English pseudo pocket. You can see that this is the there is the external bevel incision. There is given 45-degree angulation to the surface to the gingival surface, and you can see that the palatal side also they have followed the same pattern, and this has been removed with the tissue, and this is you can see that after the removal, and this is the periopack or pack given after the gingivectomy procedure. There is immediate healing after 7 days, and you can see that after 14 days you can see that there is the label view and the palatal view. So various other techniques of gingivectomy, as we told before, this gingivectomy procedure can be done by scalpel, electrocautery, or laser, or with the chemo surgery. So out of that, the most important one, that is the laser gingivectomy that we are following here. That is currently gingivectomy is the most common procedure performed with lasers. So we have different type of lasers with the wavelengths can be used for incising the gingiva for restorative, cosmetic, and periodontal purposes. And we have the surgical lasers of ARIAG, erbium, argonium, gallium, and carbon dioxide, NDAG, diode lasers. This all can be used to perform gingival or mucosal surgeries, which are perfectly controlled without postoperative pain and which heals within a few days. So only erbium lasers will be indicated for procedures on bone and gingiva. So they are particularly effective for aesthetic crown lengthening in a very critical area without the need of a flap. So that is the laser gingivectomy. So what are the advantages? As you know, these have more advantages than disadvantages. It is the first one is the most important one. There is a completely dry, bloodless surgery. Surgical time is reduced. Instant sterilization of the area. Decreasing the chances of bacteremia. Minimal postoperative pain, swelling, and scarring. Disadvantages: protective IVR should be used and high cost of the. So this is just the diagrammatic representation. I think we are daily basis we are doing cases in the department. So you can come and assist individually for the cases, for seeing the cases and for understanding how it is being done. So you can see that what are the postoperative instructions given and what is the result, what is the what is the satisfactory level of the patient after doing laser gingivectomy. So then coming to the gingivectomy by chemosurgery, this procedure is not recommended. As you know, this cannot be controlled, the action cannot be controlled, and gingival remodeling cannot be done, and the epithelialization, reformation of gingival epithelium is very slow in chemically treated wounds. And so the chemicals that have been used for chemosurgery, that is the like the paraformaldehyde that is incorporated in modified zinc oxide eugenol pack, placed the gingival margin in the pocket, and also another method uses potassium. Coming to the gingivectomy by electrocautery, so this also have been outdated. As you know, there is more trending that is the laser gingivectomy compared to electrocautery also. And what are the advantages? If you tell about the advantages, that is by for the gingivectomy by electrocautery, that is permits adequate contouring of tissue, better control of hemorrhage. And what are the disadvantages? That is cannot be used in patients with not compatible or poorly shielded pacemaker. That is the main disadvantage of this electrocautery, and it causes an unpleasant odor. Obviously, there is it is cauterization will be happen. If it touches bone, irreparable damage can occur to bone, and heat generated can cause tissue damage even. And if electrode touches cementum, it can cause there is cementum burn. So these are the advantages and disadvantages of gingivectomy by electrocautery. So this is electrosurgery unit, and these are the it is the various loops for electrosurgery. Tips for the loop is there, the incision blade is there, and the diamond loop is there. So these are the different type of uh, electrocautery tips. So coming to the subdivision, or you can tell it as a separate portion, there is gingivoplasty. Always it's needed along with gingivectomy, or it is needed alone also. So in case of recontouring the gingiva, so other than gingivectomy, other than excision, if you want to shape it, if you want to recontour the gingiva to make sluice ways for the passage of food, always gingivoplasty is needed. So it can be accomplished with the periodontal knife, a scalpel, or a rotary course diamond stones can be used. But I would say that it's more important one that is with the can be done with the knife other than laser also. I would suggest to go for gingivoplasty with my personal experience. So you can see that the procedure will be done. There is a tapering of gingival margin, especially thinning of gingival margin. That blunt, thickened margins will be smoothened and will be merged with the tooth surface, and also creating the scalloped marginal outline. So tapering the gingival margin, scalloping marginal outline, and obviously thinning of attached gingiva. If there is a thickened attached gingiva, if it is aesthetically compromising, you can thin the attached gingiva and creating vertical interdental grooves. You can see that. So vertical grooves will be created in between. So this will be creating the sluice ways for the passage of food and then shaping the interdental papilla. So these are the procedures will be done under gingivoplasty. So you can see the difference of this gingivectomy and gingivoplasty. There is a diagrammatic. There is here the gingivectomy will be the excision of gingiva. There is external bevel incision, whereas gingivoplasty we will just shape like more like an internal bevel incision. So this is a detailed procedure doing the gingivectomy and gingivoplasty together. You can see that this is the enlargement. There is a grade 3 enlargement. At least it's covering more than 3 by third fourth of the tooth surface. And using the Kirkland knife and Indian knife and this tissue nippers for just removing the um, tissue tags, and this just rotary burr stones have been used for shaping it, for that is recontouring surface. This is the immediate picture after the procedure and the copac has been given. You can see the difference from pre-operative to the post-operative. As ideally, the gingival contouring has been done and healthy gingival sulcus has been established. Coming to the healing part after gingivectomy, obviously by the second day, clot formation will be there, and by the fourth day, clot will be replaced by granulation tissue and with epithelial formation but without rectipex. Then there will be dense inflammatory infiltration, and by the sixth day, this wound will be covered by stratified squamous epithelium, and the collagen formation will get started in the connective tissue, and by 16th day there will be a complete epithelial formation with retipex. Then there will be dense collagenous connective tissue, and also this by the 21st day the epithelial retipex will be well developed with thickening of stratum corneum, increased collagen formation in the connective tissue, and gingiva clinically appear normal. So, what are the desired results after gingivectomy? Obviously, you should get a thin gingival margin, should be beveled and adapted and tightly confined to the tooth surface, and pyramidal shaped intestinal gingiva confluent with the gingival margin of adjacent teeth. Intestinal gingiva should be sloped approximately 45 degrees and have a linear indentation to form a sluice way occluso-apically, and the remaining zone of attached gingiva should be adequate and should be keratinized. So this is just the decision tree that is done for drug-induced gingival enlargements. You can see that there is gingival enlargement. If it is not present, then you can just go for the oral hygiene instruction. There is a maintenance phase. If it is present, all the phase 1 therapy will be done and reevaluation will be done. If it is persisting or if it is regressing, then again it will go to maintenance phase. And if it is persisting, obviously it will go to the surgical phase. There is a periodontal surgery will be indicated, then it will be categorized whether to go for gingivectomy, there is just the resection, or to go for regeneration, that is along with the osseous correction. If it is needed, if osseous correction is needed, you have to go for the periodontal flap surgery. And if there is nothing, just small areas of enlargement with no attachment low, no true pocket, just horizontal bone loss, abundance of keratinized tissue is there. If it is not in anterior area, you can obviously go for gingivectomy procedure. And after gingivectomy, obviously maintenance phase play an important role in maintaining oral hygiene by chlorhexidine rinse and professional recalls and use of OCD pressure appliances. And then there will be consider there is a periodic surgical retreatment. So this is the line of treatment for gingival enlargements. So coming to the conclusion, obviously there is a recurrence of chronic inflammatory enlargement immediately after treatment indicates that all irritants should be removed. So contradictory, the local conditions like food impaction, overhanging margins are often overlooked. But if the enlargement recurs after healing is complete and normal contour is attained, inadequate plaque control by the patient is the main common cause. So the removal of local irritants such as prime factor to avoid recurrence of pockets and enlargement. So that's all about gingivectomy. Thank you.